Good morning, Mohan sir.
Good morning, sir.
Good morning, sir.
Morning, Dr. David. Good morning, Dr. Soumya.
Good morning, sir. David, sir. Hello. Sir. Sir, మీ వాయిస్ రావట్లేదు జూమ్ లో.
డేవిడ్ వినపట్లేదు. Okay. Hello.
Hello.
Yeah. You are getting screen.
వస్తుంది సార్. I'm getting scared.
Good morning, sir.
Am I audible, sir?
Audible clearly. Good morning. Good morning, sir. Good morning, all of you. Sir, shall we start?
Yes, please. Start change, sir.
Please carry on, Soumya.
Good morning, seniors and colleagues. Today my topic will be the continuation of my previous talk, that is endocrine emergencies. In last talk, we have discussed thoroughly about hyperglycemia related complications, that are DKA and HHS. So now I'll be continuing or proceeding with the further endocrine emergencies. So after sir, next. So next is hypoglycemia. So hypoglycemia is defined as blood glucose below 3 millimole per liter. Roughly, it will be like 50 milligrams per deciliter. Some people with diabetes develop hypoglycemic symptom even when blood glucose is more than 3 millimole per liter. Other side, some people may not have symptoms even though they have a very low blood glucose. Those people are categorized as hypoglycemic unawareness. Next. So grossly, hypoglycemia can be classified into three groups: level 1, level 2, level 3. Level 1, where glucose is less than 70 milligrams per deciliter, but more than 54 milligrams per deciliter, that is between 54 to 70. Level 2 is glucose less than 54 milligrams per deciliter. Level 3 is a severe event characterized by altered mental state. Basically, they are the symptoms of neuroglycopenia: confusion, slurred speech, irritability, ranging to coma also. Next, sir. So there are a lot of classifications associated with hypoglycemia. American Diabetes Association gave a crude classification in a 2005 report, in which they have categorized into 5 categories. The recent 2017 ADA guidelines classified as discussed in our previous slide. So the old classification goes like this. It is categorized into severe, where the symptoms require active assistance of another person to treat, and it is independent of blood glucose. Second, documented symptoms. That means there is a documentation of low glucose, and the patient is symptomatic also, mostly self-treated. Third, asymptomatic. These people have a recorded low glucose levels, but they don't have any typical symptoms. They are hypoglycemic unaware people. Fourth, probably symptomatic. Symptoms of hypoglycemia persist, but they are not usually accompanied by any blood glucose determination. Last is pseudo-relative. They have typical symptoms of hypoglycemia, but usually if we check the blood glucose level, there will be more than 70 milligrams per deciliter. There is another classification, that is Canadian Diabetes Association 2013 classification. They categorize it into mild, moderate, severe. Mild is something where symptoms are present and then individual can treat by himself. Moderate, where autonomic and neuroglycemic symptoms are present, may self-treat or may require assistance. Severe, definitely they require assistance. They have severe neuroglycopenic symptoms ranging from confusion to coma, and usually glucose levels will be less than 50 milligrams per deciliter. Next. So the triad of hypoglycemia is called as Whipple's triad, where we see the symptoms of hypoglycemia and accompanied by a plasma glucose level less than 50 milligrams per deciliter. And usually these symptoms resolve after plasma glucose levels are increased. And there is a rule of thumb, that is unless otherwise proved, all the unconscious patients should be given a 25% dextrose, that is glucose, because hypoglycemia is most common cause of unconsciousness. Next, sir. So what is the pathophysiology behind this hypoglycemia? Usually hypoglycemia or hypoglycemia, for that matter, many endocrine emergencies are related to the counter-regulatory mechanism imbalance. So as glucose levels decline, the major defenses in our body should be a decrease in insulin secretion, an increase in glucagon secretion to promote glucose secretion, an increase in epinephrine secretion, whereby cortisol and growth hormone are increased, thereby increasing glucose levels. If these defense mechanisms fail, the plasma glucose levels continue to fall. Usually these defense mechanisms fail mainly in a long-standing diabetes patient. So that's why they present lately with the symptoms of hypoglycemia. Next, sir. So the causes. Causes can be broadly classified into drugs, tumors, or miscellaneous. Drugs, most common cause are insulin and OHS, oral hypoglycemic agents, alcohol, salicylates, quinine, beta blockers, pentamidine. And another important thing is prescription errors, that is chlorpropamide for chlorpromazine. Chlorpropamide is a OHS, sulfonylurea, where mistakenly it can be taken for a chlorpromazine, that is a tranquilizer and anti-anxiety drug. Next, tumors, insulinoma or any retroperitoneal sarcomas secreting insulin. Miscellaneous, that is liver dysfunction, adrenal insufficiency, hypopituitarism leading to low cortisol, low glucose levels, renal failure, mixed edema, and other most important cause in ICU is sepsis. In sepsis, we see with the patients with hypoglycemias. So the presentation. Usually the presentation can be classified into autonomic or neuroglycopenic symptoms. Basically, autonomic symptoms appears first when the glucose levels are in a mild level, that is between 54 to 70 milligrams per deciliter. It is characterized by diaphoresis, anxiety, palpitation, tremor, warm feeling. Basically, the patient himself says that something is happening to me, I'm perspiring. These are the autonomic symptoms. Next is neuroglycopenic symptoms, where the flow, that is less than 30 milligram per deciliter. Patient may not be able to communicate what is happening to him. It is characterized by confusion, slurred speech, being uncoordinated, focal neurological deficits, coma, or seizures. Next. So it is broadly classified into autonomic, neurologic, or non-specific symptoms. Non-specific symptoms include headache, dizziness, generalized weakness, and paresthesias. This usually occurs in glucose levels more than 70 milligram per deciliter, but less than 90 milligram per deciliter. As the severity of blood glucose levels fall down, first autonomic symptoms appear, then neurological symptoms appear. Next. there is this entity called as nocturnal hypoglycemia. It is usually seen in patients with type 2 diabetes for a long period. Usually this occurs between 2 to 4 a.m. This diabetic patients gets up in middle of the night, says that they are having palpitation, they are having impending sense of doom, and usually the diagnosis is through GRBS, bedside GRBS, and symptoms will be easily relieved by giving a simple carbohydrates or any complex carbohydrates. And the treatment should be, there should be any decrease in dose of insulin, that is bedtime insulin should be decreased, and the timing of insulin should be adjusted. Maybe they require the change of type of insulin also. Next. So how we diagnose hypoglycemia? Basically, there will be a panel of tests. We'll start with blood glucose level, urine electrolytes, liver profile to see any liver dysfunction causing hypoglycememia, insulin, C-peptide levels to see whether insulinemos are present, sulfonylurea screen, whether they are having more OHS in their blood, IGF-2, alcohol level, salicylate levels, and whenever required, imaging is to be done to screen out any carcinomas or insulinomas. So basically, the algorithm should be if there is if there are symptoms of hypoglycemia, and if you have a evidence of a capillary blood glucose less than 70 milligram per deciliter and hypoglycemia is confirmed, we should look for whether the patient is having a diabetes or not. If diabetes is present, then our flowchart should follow as what are the medicines he is taking, extra medicine, did he skip meal, and should be followed accordingly. If the patient is not having diabetes, and if at all possible, should always take a critical blood sample. That is, when the episode is happening, you should take a blood sample, and it should be analyzed for multiple things like insulin, C-peptides, and everything. So if the patient is conscious and able to take orally, that is in a mild variant, he should take simple carbohydrates, maybe a juice or a sugar, and it should be always followed with a repeat blood glucose level, capillary blood glucose level after 15 to 20 minutes. If it is persistently low, again he can have something, and again should be repeated after 15 to 20 minutes. If it is persistently still low, should go to hospital. If the patient is not conscious, then we should look for an IV access. If IV access is available easily, then we can always give a dextrose infusion. If IV access is not available easily, then glucagon injection should be given IM. We get it as a 1 milligram. Ampoule will have a 1 milligram, so we should be given for adults. If the patient or is a pediatric patient or less than 25 kgs, half of the vial should be given. And again, we should wait for 15 to 20 minutes to take the reading. Parallelly, should assess the symptoms also. If after to 15-20 minutes the symptoms doesn't resolve and patient is still having the low blood glucose levels, again we have to repeat glucagon and try for IV access to give a dextrose infusions. So glucagon should be an emergency drug which should be available in our ER and ICUs. Next. So next, thyroid emergencies. So just a brief physiology of thyroid. Basically, hypothalamus secretes thyrotropic releasing hormone, which on positive feedback loop secretes acts on pituitary gland and secretes TSH, which on further positive feedback loop acts on thyroid gland to secrete the thyroid hormones that are T3, T4, and calcitonin. So T4 is an inactive form and T3 is active form. There is another isomer of T3, that is RT3. We call it as RT3. Basically, T4 is inactive form and it is almost 90% T4 is secreted from thyroid gland. T3 is metabolically active. Almost 9% of it is available in circulation. Reverse T3, RT3 is isomer of T3, which is inactive metabolite of T3. It is present about 0.9%. So usually T4 is converted to T3 and it is a metabolically active form. Next. So the factors that affect the thyroid function. Factors contributing to production of thyroid hormones are basically lot of minerals and micro minerals, that are iron, iodine, tyrosine, zinc, selenium, vitamin E, B2, B3, B6, and C and D. Factors that inhibit proper production of thyroid hormones, which is our point of concern. That is most common cause stress, second most infection, trauma, radiation, medications, and toxins like mercury, cadmium, lead, or any autoimmune disease, which is also in rise in last few years. Next, sir. So first, thyroid storm. As the name itself suggests, we have excess of thyroid hormones. So it's a life-threatening hyperthyroid state with a decompensation of one or more organ systems. Almost the mortality is 20 to 30% if it is not treated at a emergency. So it is usually precipitated by stress or easily precipitated by stress, infection, surgery, and pregnancy. So we can't diagnose it when we have an emergency, as we can't get a test immediately. So next, sir. So we have a series of, we have a characteristic features of hyperthyroid which should be taken into consideration. So the precipitating factors for thyroid storm can be infection, any non-thyroidal trauma or surgery, psychosis, pregnancy, diabetic ketoacidosis, any acute states like myocardial infarction or any acute medical problems. So specific thyroid reasons can be usage of radioiodine, high doses of iodine containing components like contrast media, discontinuation of any anti-thyroid drug treatment, thyroid injury, or any new institution of amiodarone therapy. Next. So usually the symptoms can be categorized into hypermetabolic state symptoms, increased sympathetic activity, and increased cardiac effects. So as thyroid is a hormone, we all know that it controls metabolic activity, it increases glucose metabolism, it increases protein synthesis. Basically, thyroid acts on each and every cell of the body. So as it increases the metabolism, hypermetabolic state is usually seen in thyroid storm, where there is an increase in general metabolic rate and increase in over metabolic rate. There will be heat intolerance, excessive sweating, skin becomes soft, warm, always flushed and moist. There is an increase in sympathetic activity, and there will be a proliferation of catecholamine receptors. Further, more sympathomimic catecholamines act on it, and the effects can be seen as a wide gaze, ocular symptoms like wide gaze or lid lag, overstimulation of gut, hypermotility will be there, diarrhea can be seen, malabsorption, they are thin built because of both diarrhea and hypermetabolism. CNS overstimulation can be seen seen as nervousness, irritability, easily getting irritated, tremors. Cardiac overstimulation is seen, which is manifested as cardiac arrhythmias, and cardiac effects are manifested basically because of increased heart rate and contractility, that is increased inotropy and chronotropism. So there is an increased cardiac output, palpitations and tachycardia are usually seen. So overall, next, sir. On a broad note, we usually see bulging eyes, lid lag, wide gaze, tachycardia, increased BP, weight loss because of both the high metabolism and diarrhea, muscle wasting, menstrual changes, finger clubbing, always. Hello. Next. So there is this diagnostic criteria to criteria for thyroid storm. This is very important because initially when the patient comes with the above symptoms, we can't label him as a thyroid storm patient based on tests because they can't be available on bedside. So there is this scoring system which takes into consideration of 5 important things, that is thermoregulatory dysfunction, central nervous system effects, gastrointestinal or hepatic dysfunction, cardiovascular dysfunction, heart failure. And further, for each component, they have given a scoring based on the findings in that. So if the total scoring is less than 25, the patient is unlikely to have a thyroid storm. If the patient score lies between 25 to 44, it supports the diagnosis of thyroid storm. And if the patient score is more than 45, it is highly suggestive of thyroid storm. Next. So then if we have suspicion of thyroid storm based on the symptoms, then what are the laboratory investigations to be sent? Basic blood workup should be sent, which consists of CBP or urea, electrolytes and all. Then the most important thing to be sent is free T4, T3 levels, which are usually elevated, very high in this patient. And TSH is usually suppressed in this patient. And the other findings supporting to a thyroid storm includes patient usually has high glucose levels, leukocytosis, mild hyperglycemia. Next, sir. So, how to differentiate between an uncomplicated thyrotoxicosis and thyroid storm? It is just nothing but the features will be a milder form of a thyroid storm features. So usually this uncomplicated thyrotoxicosis patient has heat intolerance, diaphoresis, they'll be perspiring all the time, tachycardia, anxiety, palpitations, diarrhea. They have a history. They'll be having a history of weight loss, anxiety, and restlessness. The severe form of these symptoms will be usually seen in a thyroid storm. Next. So the treatment, coming to the treatment of the thyroid storm, as we know, the symptoms are mostly pertaining to the cardiac effects, sympathetic overstimulation, and increased metabolic rate. Our target should be to decrease the sympathetic flow, decrease production and release of thyroid hormone, and decrease the peripheral conversion. So first target should be to act on the symptoms. Next, to decrease the peripheral conversion. Next, to decrease the production of the and release of the thyroid hormone. Next. So management, basic ABC, airway breathing circulation assessment, rehydration should be ensured. And first and foremost, we should always treat the hyperpyrexia by all the measures possible, cold salines and everything. And we should not use aspirin as an NSAID of choice, because aspirin can displace T4 from the binding sites, where it ensures the conversion of T4 into T3, whereby symptoms can further worsen. Next. So the drugs in the order of administration can be first beta blockers. It decreases the sympathetic hyperactivity and partially blocks peripheral conversion of T4 to T3. Usually given drug is propranolol. Second, propyl thiouracil. It blocks synthesis of thyroid hormone, decreases conversion of T4 to T3, and faster onset of action than methimazole, and usually preferred drug of choice in pregnancy. Next, methimazole. It blocks synthesis of thyroid hormone, but it is teratogenic. So usually preferred drug will be propyl thiouracil, that is PTU. Next, iodide. It inhibits release of stored thyroid hormone. It should be administered only after synthetic pathway has been blocked by propyl thiouracil or methimazole. Steroids. It decreases peripheral conversion of T4 to T3, and it can also treat in autoimmune diseases. Next. Next, sir. So take home points for thyroid storm: always treat the symptoms first. We should always try to decrease the sympathetic outflow, decrease the temperature, then look for the cause, send the labs, and then block the conversion of the T4 to T3, then block the release of hormones. Next. So next, myxedema coma. Thyroid storm is characterized by increased hormones of increased thyroid hormone, whereas myxedema coma is decreased thyroid hormones. Next. So it is a severe hypothyroidism that can lead to decreased mental status, hypothermia, and other symptoms of slowing or failing of multiple organs. Even it is also an emergency with carrying a mortality rate of almost 80 to 20%. Next. So the precipitating factors can be hypothermia, infections, especially pneumonias, myocardial infarction or congestive heart failure, any CVS, respiratory depression due to drugs, trauma, or GI blood loss. Next. As we know, there is a decrease of thyroid hormones, that is T4, whereby there will be decreased conversion of T4 to T3. So available metabolic activity T3 is also less. The CNS effects are seen as altered mental states. There is decreased thermogenesis, which is manifested as hypothermia. Usually these people lacks the sensitivity to hypercapnia. That is usually when carbon dioxide is more, our respiratory center is stimulated to increase the ventilation, but this reflex is lost and they have a respiratory insufficiency, which is manifested as cerebral anoxia. Cardiovascular, there is decreased inotropism and chronotropism, whereby there is decreased low blood volume and can be manifested as low blood pressure or shock. Fluid balance, there is increased vascular permeability. Usually there will be capillary leak and the patients will be waterlogged, and can be seen as a waste patients. So all this put together, they can be contribute to coma. Next. So typical features of hypothyroidism: intolerance to cold, receding hairline, facial and eyelid edema. Patients are waterlogged. They have this dull, blank expression, extremely fatigue, apathy, lethargic, constipated all the time, and menstrual disturbances. The emergency findings can be respiratory insufficiency, bradycardia, low blood pressure, or shock. Next, sir. So physical findings, usually we can easily identify the patients once we see these patients. They have the typical features of hypothyroid state, comatose or semi-conscious. They have dry coarse skin, and the most important clinical finding is delayed reflex relaxation time, that is called as Walton's sign. Where is the which reflex is which duration is prolonged in these patients after a deep tendon reflex is initiated. Basically, this is due to impaired calcium sequestration by sarcoplasmic reticulum. Next, sir. So all the labs should be sent. Basic workup, routine blood workup, and electrolytes, liver profile, renal profile has to be sent. Usually, free T4 is very low and TSH is high. If the T4 is low and TSH is low normal, we should always consider a pituitary hypothyroidism. The most important thing in ICUs is we should always differentiate it between hypothyroid state or euthyroid 6 syndrome. In euthyroid 6 syndrome, it is characterized by low T3, normal or low TSH, but normal or free T4. Next, sir. So management, we start with the airway breathing circulation assessment. Gradual rewarming with blankets should be ensured. Core temperature should always be recorded by rectal thermometer, and fluid should be judicially given to treat low blood pressure or shock state. Next, coming to the replacement, thyroid hormone replacement with L-thyroxine 300 to 400 micrograms is usually given via nasogastric tube. Alternately, doses of triiodothyronine, that is 10 micrograms, 8 to 10 hourly, may be used. Next. And as these patients have a low metabolism or hypo states, hydrocortisone can be useful, which is given to be stat doses and should be repeated every 6th hourly. We should always correct the electrolyte imbalances. And as we know, there is a respiratory insufficiency, hyperventilation is going on. If required, we should ventilate patients if the patients are near to coma, and always treat the precipitating cause, because infections are usually masked in hypothyroid state. Next. So that's about thyroid emergencies, thyroid storm and myxedema coma. Next, coming to adrenal gland emergencies. Next. So brief physiology or anatomy of adrenal gland. So adrenal gland, it is divided into gland per se is divided into both cortex and medulla. Further, cortex is divided into 3 zones, that is zona glomerulosa, zona fasciculata, zona reticularis. Zona glomerulosa is the first layer. It secretes mineralocorticoids, that is aldosterone. Zona fasciculata secretes glucocorticoids, that are cortisol and cortisone. Zona reticularis secretes androgens. Adrenal medulla secretes stress hormones, that are epinephrine and norepinephrine. So the function of mineralocorticoids, we all know, to retain sodium, whereby water retention. Glucocorticoids, cortisol is important for glucose metabolism and to decrease the inflammation. Androgens, that stimulate masculinization. Stress hormones, basically everyone know, they are hormones of flight and fright. They combat the stress situations. Next, sir. So basically, adrenal glands are very sensitive to the stress factors. So easily the stress factors or infections can increase the epinephrine and norepinephrine secretion. Next. When there is the stress response to adrenal gland, basically the stress response of adrenal gland can be seen as a short-term stress response and long-term stress response. There is a slight difference between the short-term stress response and a long-term stress response, because when the patient is having the short-term stress response is basically manifested by secreting epinephrine and norepinephrine, whereas long-term stress response is due to secretion of mineralocorticoids and glucocorticoids. So short-term stress response, adrenal medulla is into action, whereas long-term stress response, adrenal cortex is into action. So short-term stress response causes increase in blood glucose, increase in blood pressure, increase in breathing rate, basically increase in metabolic rate. And long-term stress response is related to the mineralocorticoid and glucocorticoid release. Next. This is the reflex, positive feedback reflex of a adrenal gland. Hypothalamus secretes corticotropic releasing hormone, which acts on anterior pituitary to secrete ACTH. ACTH further acts on adrenal gland. Adrenal gland, if it acts on if it increases aldosterone, it has a aldosterone high its own effects. Where if it stimulates cortisol, it has its own effects. The aldosterone effects are manifested as sodium retention, water retention, potassium excretion, and calcium excretion. Whereas cortisol effects are manifested as anti-inflammatory effects, gluconeogenesis, protein metabolism, and fat metabolism. So excess of aldosterone, that is hyperaldosteronism, is called as Conn's disease, whereas lack of aldosterone, that is hypoaldosteronism, is called as Addison disease. Called as Addison's crisis or acute adrenal insufficiency, which is related to the hypoaldosteronism. On the other side, on the other side, excess of cortisol is called as Cushing's syndrome or Cushing's disease. Usually, on a general basis, if a corticoid excess is manifested, is seen, or it is always manifested as glucocorticoid excess, but a general lack of corticoid is always manifested as a mineralocorticoid deficiency. Next, sir. So coming to Addison's disease, it can be primary or secondary. Primary is basically due to destruction of adrenal cortex. Cause may be anything, autoimmune disorders, tuberculosis, or any chronic infection. Whereas secondary Addison's disease is due to lack of ACTH, that is lack of loop. This is caused by drugs, tumors, infections of the pituitary gland. Usually the treatment of primary Addison's disease will be both cortisol and aldosterone. Whereas secondary, as ACTH is at fault, only cortisol should be enough to create a positive feedback. Next, sir. So features of Addison disease. They have this typical bronze pigmentation of skin, hypoglycemia. They always have postural hypotension. As the function of aldosterone is to retain sodium. In Addison disease, there is a lack of aldosterone, so sodium is not retained, thereby water is not retained. Usually they have low volume state, and this is manifested as a postural hypotension. They also have a GI disturbances, weakness, and weight loss. The typical features of adrenal crisis, which is of our interest, emergency, that is profound fatigue, dehydration, vascular collapse, renal shutdown, decreased sodium, and increased potassium. Next. So usually this adrenal insufficiency patients has this bronze patches on unexposed areas of skin. This on buccal mucosa we can see it as a brown patches, multiple brown patches. Next, sir. So Addison disease, it's a chronic adrenal insufficiency, whereas hyperaldosteronism, as said, it is a Conn's disease. So always we should differentiate between primary and secondary aldosterone because treatment depends upon that. And coming to Conn's disease, that is primary hyperaldosteronism. If the Conn's syndrome is due to adrenal aldosteronoma, that is tumor of adrenal cortex, surgery is the only option. If the Conn's disease is due to bilateral adrenal hyperplasia, we can't do any surgeries. Usually to treat with potassium sparing diuretic. Next. So how to diagnose? Basically it is by cortisol. Usually we measure 8 AM cortisol, that is early morning cortisol levels. If the cortisol level is more than 15 micrograms per deciliter, usually adrenal insufficiency is ruled out. If the cortisol level is less than 3 microgram per deciliter, usually adrenal insufficiency is confirmed and further should be proceeded with the measurement of ACTH. If the cortisol level is in between, that is between 3 and 15 micrograms per deciliter, we should start with a cosintropin stimulation test. Cosintropin should be given, and 30 minutes later cortisol should be measured. If the levels are more than 18 microgram per deciliter, then adrenal insufficiency is ruled out. If levels are less than 18 microgram per deciliter, again we should proceed with the ACTH levels. So if ACTH levels are low or normal, usually it is secondary or tertiary adrenal insufficiency. If they are pertaining to the gland. Next. So management of acute adrenal insufficiency, as a rule of thumb, always start with airway breathing circulation assessment. Usually hydrocortisone is must in this patient. 100 mg stat, that is followed by 50 mg fourth hourly, and we should always taper slowly after 72 hours. Meanwhile, we'll get the labs to see the primary cause. Next, before and judiciously we should give them fluids, as they have tend to have a low BP and in a shock state, and maybe low glucose level. So 5% dextrose should be given as and when required. Next. So and another important thing is, if it is due to ACTH, only cortisol will be enough. But if it is primary adrenal insufficiency, mineralocorticoid therapy should also be given. That is both fludrocortisone and hydrocort, both to be given. Next. So this is this is all about mineralocorticoid excess or deficiency. Next, coming to the cortisol, cortisol excess. It is manifested as Cushing's disease or Cushing syndrome. Always we should differentiate between whether patient is having a Cushing disease or Cushing syndrome. So what is Cushing disease and how it is different from Cushing syndrome? Basically, in both, cortisol is in excess, but the primary cause is different. In Cushing disease, it is due to tumor on the pituitary gland that causes the gland to secrete too much ACTH. Whereas in Cushing syndrome, they generally have increased cortisol levels that may be exogenous source or any other cause. So basically, Cushing's disease is a part of Cushing syndrome. Cushing syndrome is overall increase in overall excess cortisol levels. Next. So features of Cushing syndrome. They have this typical features of moon face. They call it as a moon face. Fat deposits are seen on back, called as buffalo hump. As cortisol is in excess, there is sodium and fluid water retention will be there. So there will be this central obesity will be present, but they have thin arms. So the typical characterization of Cushing syndrome patient will be moon face, buffalo hump, central obesity, thin upper limbs and lower limbs, hirsutism, purple striae, bruises and easy pedicle hemorrhages are seen all over the body. Easily tend to have fractures as osteoporosis is seen. So next, Cushing syndrome. So how to diagnose it? So we have to see whether exogenous glucocorticoid exposure is seen for any other reason or not. Then we should send 24 hours urine-free cortisol test at least twice, or overnight 1 mg dexamethasone stress test, or late night salivary cortisol levels, or a 48 hours 2 mg dexamethasone stress test. If they are normal, Cushing syndrome is unlikely. If they are abnormal, we should always perform a second test to prove whether it is abnormal or not, and to diagnose as a Cushing syndrome. Next, sir. So how to do a dexamethasone suppress test? So when we have this patient with the features of typical Cushing syndrome, buffalo hump, moon face, and all the things, we should do a urine-free cortisol 24-hour assay. Also do it or a dexamethasone suppression test. Usually dexamethasone is given at night 10 p.m. and cortisol levels are measured in the morning 9 a.m. because of the circadian rhythm. So there are it can be done it can be done as either low dose test or a high dose test. Low mg of dexamethasone is given and cortisol levels are measured in the morning. So if after giving a 1 mg dexamethasone in the night and low cortisol is seen or noticed in the morning, then it is okay, normal. If higher normal cortisol levels are seen, then it is diagnosed to have a Cushing syndrome. Other side, high dose test, 8 mg dexamethasone is to be given. If low cortisols are seen in the morning, Cushing's disease is diagnosed. Cushing disease, that is basically because of the pituitary. If higher normal cortisol levels are seen, then further we should proceed with the measurement of ACTH levels. If ACTH levels are low, it is adrenal Cushing's. If ACTH levels are high, it is ectopic ACTH. Next. So coming after diagnosis of origin or whether it is a Cushing disease or Cushing syndrome, whatever it may be, that but treatment initial management is same for all the patients. So that is airway, breathing, circulation, and treating the symptoms. So next, Cushing syndrome, if it is caused by corticosteroid use, we should always start with decreasing the dose of corticosteroid. We should never stop it abruptly, as it is generates negative feedback loop again. If Cushing syndrome is caused by pituitary tumor or the tumor that releases ACTH, surgery is the choice. Transsphenoidal approach or anything open can also be done. Usually nowadays transsphenoidal approach is done. So surgery to remove the tumor and radiation after removal of pituitary tumor in some cases, if the symptoms persist or if we see any remnant gland. And cortisol therapy may be needed further throughout the life. If Cushing syndrome is due to adrenal tumor or any ectopic tumors, ectopic secreting ACTH tumors, surgery and removal of the adrenal tumor or ectopic tumors should be done, and further, if required, cortisol should be given. Next. Thank you, sir.
Thank you, Soumya. Very nice presentation, and very important and very volatile subject actually. And we are frequently missing in ICU of this type of cases of endocrine emergencies other than hyperglycemia or hypoglycemia and regular things. But this type of Conn's disease, Cushing's, and Edison's disease, and aldosteronism, hyper or primary or secondary, all these things we are missing in ICU. We are unable to, after few days, patient is deteriorating, then only we are trying to do all these things. It's a very important topic. Actually, you need to present one by one, not in a single class. Anyway, it's a nice presentation. I'm requesting the audience to respond. Hello,
Hello.
sir.
Hello.
Chappan sir, adagandi.
This actually hypoglycemia, usually in a patient who is in septic shock. Sometimes the peripheral capillary sugar, what we monitor, it will show very low.
Yes.
At that moment, we need to check the arterial. Just this is only a suggestion to juniors.
We recently have a patient, sir, 2 days back in severe septic shock. So we checked the capillary blood glucose. It was as a protocol in ICU. It was continuously showing low, even after giving 25% dextrose. Then we got a doubt and we took a femoral vein sample simultaneously, which showed a 240 mg per dl of sugar. So
Yes.
always in sepsis or shock, where capillaries are very poorly perfused, it shouldn't be a choice, I guess.
So actually recently we also had one patient, we also checked peripherally all the time, giving 25% extra also not increasing, and a good company, Claris only. So maybe this is the reason we should have checked if the BP is normal. That is another thing we have to look into, because we had a lot of doubt about the company.
We got prepared to give a glucagon also, sir. So then meanwhile, it just tried and we checked the femoral vein, central vein sample. So it was normal only.
Now, what happens is usually it will be 15% difference, but when the perfusion is very poor, the difference is huge. So many times we have seen that sugar is only 30, 40 in capillary, but it will be around 300, 400 in the arterial blood. Yes. But this is only when the patient is in shock.
You should check RBS also, no?
Sir?
Whenever you take ABG, that time you should check RBS also, right?
Depending on the requirements.
RBS will be displayed in the ABG itself.
Sir, if art line is there, usually we take that sample only to check a capillary blood glucose, sir. We won't do a finger prick.
Are
But
you sure,
art-
David? Every ABG
Yes, sir.
will show that? Yes.
My ABG and majority of the ABGs will 90% of ABGs will, unless otherwise it is removed from the ABG. It 90% of ABG machines will give blood sugar in millimoles. So 18.5, I think 18.5, 1 millimole is equal to 18.5 milligrams. That conversion is there. Sometimes we identify hypoglycemia by looking at the ABG itself.
డేవిడ్ మాకు మిల్లీగ్రామ్స్ లోనే ఇస్తుంది డేవిడ్.
అదే సార్, మీరు కన్వర్షన్ అది పెట్టుకొని మాకు మిల్లీమోల్స్ ఓకే. ఎనీవే మాకు చేసిన వెంటనే మా గ్రూప్ లో డిస్ప్లే వస్తుంది అది. Somebody will identify and they will like that only we identify that hemoglobin is very high and it is unable to, machine is unable to assess that. It will go blank. Then immediately we advise to give that methylene blue. We few cases identified like that. Soumya, how do you different? You said primary aldosteronism and secondary aldosteronism.
primary aldosteronism and secondary aldosteronism, sir. By ACTH level, sir.
Can you explain that?
I would like to show you that flow chart, sir. Next, sir. Next,
Edison's.
next, sir. సార్ మీరు వెనక్కి వెళ్తున్నారు.
వెనక్కి అది
అడ్రినల్ గ్లాండ్ దగ్గర కావాలి.
ఇంకా అంటే ముందుకు రాలేక.
ఐ మీన్
హియర్
నెక్స్ట్
దిస్ వన్
నెక్స్ట్ ఇక్కడ సార్.
చెప్పు ఒకసారి.
Sir, so usually we start with measuring 8 AM cortisol. I mean early morning cortisol levels. If cortisol levels are more, anyway adrenal insufficiency is ruled out. If cortisol levels are low, that is less than 3 microgram per deciliter, we should always measure ACTH. If ACTH is elevated, usually primary adrenal insufficiency is diagnosed. If ACTH is low or normal, but cortisol is low or normal, but cortisol is low, then secondary or tertiary AI is considered.
AI and aldosterone is same.
Insufficiency.
Yeah. Adrenal insufficiency and aldosterone is same.
More or less same, sir. Most probably.
To be precise, idena?
Sir?
ACTH test ante idena?
Sir, ACTH test అంటే ఇదే సార్. కోసిన్ట్రోపిన్ స్టిమ్యులేషన్ టెస్ట్ ఆర్ ACTH టెస్ట్ రెండే ఉంటాయి సార్. మనకు కోసిన్ట్రోపిన్ స్టిమ్యులేషన్ టెస్ట్ ఆర్ ACTH, అక్కడికి వచ్చి డెక్సామెథాజోన్ స్టిమ్యులేషన్ టెస్ట్.
ACTH టెస్ట్ ఇప్పుడు వ్యాలిడిటీ లేదంటున్నారు కొంతమంది, నిజమేనా?
But even now endocrinologists do it, sir.
Basically in the ICU, sir, ICU there is no role of ACTH test. Only we need suppose
సర్వైవింగ్ సెప్సిస్ గైడ్ లైన్ స్టార్ట్ చేసినప్పుడు 2010లో ఎప్పుడో చెప్పారు, 10 ఏళ్ల కిందట.
We are doing in case of septic shock. There is no role. This is different.
Sir, no role, sir. No role.
There is no role in septic shock by doing the ACTH and give steroids.
But in a non-ICU setup,
yes,
patient is stable. So in that condition, sir, what is the problem, secondary or primary, to know we need to do ACTH stimulation.
And another thing, if the patient is in crisis, we can't do it, sir. By the time we'll give the steroids or everything. If patient is having symptoms but not in crisis, we can always do it.
No, even before you give also. So shock trials, septic shock trials, they found that there is no role, and they need to look into genetically also nowadays. At that time they found that if you do a test and give hydrocortisone, or if you don't do a test and give hydrocortisone. If there is an insufficiency is there, if there is no insufficiency, there is no differences between the outcomes of the patients. So that's the reason why ACTH stimulation test is stopped.
Majority of the old people coming to ICU with dyselectrolytemia, edema, drowsiness, altered sensorium, and no proper history, not taking proper food. So this type of patients, majority have this endocrine deficiencies. How will you? Is there any protocol or any thing to identify this, Soumya? Chart.
I couldn't find out any protocol as such, sir. Whenever symptoms are in doubt, we should always do it. But as sir said, not in a scenario of sepsis or septic shock.
Yeah, there is no septic shock or sepsis, but patient is old man, 70 years, drowsy.
Typically, the description which you gave, it will be-
Dyselectrolytemia like hyponatremia or hyperkalemia or hypokalemia, and not unable to walk, unable to do anything, and this type of patients are coming. We are unable to identify what is the proper cause. Is there any flow chart for this?
No, sir.
Hello.
As such indications in ICU when we should do it.
Hello.
Anna, మాట్లాడు.
The patient comes to us, and as you said that these symptoms are there, then we go with the basic investigation. We found we just rule out the encephalopathy for evaluation. So maybe hypoglycemia is ruled out. We might find there is hyponatremia. Immediately, our next phenomenon is just send the evaluation for hyponatremia and start 3% saline. So we already like muddle the internal environment by giving some exogenous medications. So obviously getting an investigation and confirming the reasons for like particularly related to adrenaline or something like, it's very difficult at that point of time because we already started treating the symptoms. More so it's like that's why we miss these diagnoses mostly. The patient coming in the state.
Sepsis లో ఉన్నప్పుడు
Sir.
చెప్పండి సార్ చెప్పండి.
So more so when we see a patient who is lethargic and very dull and all these things, the first thing we do all the investigations that is related to acute confusion state or encephalopathy. In that we rule out renal causes, liver causes like hypoglycemia, any drug causes. So all these things we initially send basic investigations, and if next within half an hour we'll get there is hyponatremia mostly, and we start treating the patient with 3% saline. Depends upon. So usually when once you start treating the patient, there will be positive feedback and reverse feedbacks happens to our medication, and ultimately we miss the diagnosis. So it's difficult to pinpoint a diagnosis that is related to adrenal insufficiency in a patient who is having the symptoms what David has narrated.
Mostly they are Addison's disease, no?
Yeah. It's a programmed diagnosis. See, it is a programmed way of diagnostic tool, but in ICU settings, we are not like we don't have that much of time. No, we start treating the patient.
Madam?
Sir.
David, are we anybody doing cortisol levels in ICU these days?
No, madam. No, we are not doing. But sometimes
probably in ICU, most of the patients, maybe they have critical illness, adrenal insufficiency problem. That's why we see all this, right? So empirically, like sepsis not responding to dual vasopressors also one of the cause of this. So maybe that's why we are starting straight away with steroids, hydrocortisone. But as Satish,
my case scenario is patient old, lethargic, confused.
Said like hyponatremia, all this also probably. Yeah.
Yes, madam. In case of dyselectrolytemia, madam, sodium is not very low. It is 125. Potassium also like 2.9. Patient is lethargic, edematous, and not in shock. No evidence of sepsis. This type of patients, I'm talking. Then I think you need ACTH or cortisol levels.
Yeah,
we need a
sometimes.
evaluation.
Yeah, sometimes we are doing early morning cortisol levels in such cases. What you said, it's not clear cut sepsis.
Yeah, that's
So,
right.
but all these problems, probably, yeah, I think some occasionally I remember doing cortisol levels, but not in clear cut sepsis cases.
Yes,
Yeah.
this case will respond with steroids, not with sodium, because the sodium is not very low, 125 like that. You need not get any 3% saline. Once you do the cortisol levels, if it is a adrenocortical insufficiency, typical Addison's disease, then a patient will respond well with steroid.
And for that,
And
madam,
would you supplement with fludrocortisone as well,
Sodium plus cortisol,
David?
మేడం చెప్పండి. హలో
Would you subcortisone,
మేడం
David?
చెప్పండి మేడం చెప్పండి.
అదే వినిపించిందా? In such cases, would you also supplement with the fludrocortisone along with hydrocortisone అని అడుగుతున్నా.
అది ఆ అమ్మాయి చెప్పింది కదా ఇందాక. సౌమ్య, కెన్ యూ ఆన్సర్ దిస్?
Madam, if it is fludrocortisone use ఒకవేళ ప్రైమరీ అయితేనే యూజ్ ఉంటుంది మ్యామ్. ఇఫ్ ఇట్ ఇస్ సెకండరీ ఆర్ టెరిషరీ, we don't require fludrocortisone. We won't require.
Okay, thank you.
Because cortisol is a deficiency, madam. Once cortisol in the form of steroid or something is given, the loop is generated. So automatically fludrocortisone, mineralocorticoid effects, they are exhibited. So if it is primary adrenal insufficiency only, then we'll require a fludrocortisone. Otherwise, as you said, madam, by the time only if we start a steroid, if it is a secondary or tertiary cause, the loop is generated. So we won't have any requirement of it.
Okay,
other than regular patients, madam, as you mentioned, doesn't need in the ICU patient to wait till morning and do a high cortisol level, because the sleep wake cycles are different in ICU. So we can do as soon as the patient comes. If you have suspicion, you can do a send up for a serum cortisol level.
Even hyponatremia flow chart also, algorithm also we follow and we send it to thyroid levels.
Yes, అదే అంటున్నాను. అంటే హైపోనాట్రిమియాలో కూడా కార్టిసాల్ చేయాలి అంటే మార్నింగ్ వరకు వెయిట్ చేయాల్సిన అవసరం లేదు, ఇమీడియట్ గా పంపించండి.
Whenever we see, we do it.
I think in the reference levels they also give the timings, right? Morning levels and daytime levels, normal levels and all the limits. So,
yes, madam. Yeah. Because we sleep and go no, madam. The stable patients. So stable patients, there will be reference values, madam.
Okay, thank you.
In septic shock, if patient is T3, T4, TSH levels, all three are low. Will you treat the this enzymes, or we need to do any tests for the confirmation somewhere?
So all the three are low, sir.
Yes.
All the three, they won't go.
This come under CQ thyroid, so we should not treat it at present, and we should treat the cause of the sepsis.
If it is hypothyroidism, associated hypothyroidism is there.
It is a clear-cut hypothyroidism. You have to treat it.
How will you differentiate?
Sir, this TSH will be elevated, no, in hypothyroidism. Here is a CQ thyroid, TSH also will be low.
Low or normal?
Low or normal?
Yes.
What is the role of reverse T3?
Reverse T3, it is an isomer of T3, sir. It is inactive. Usually, it can be converted to active form.
What they said, in this scenario, we have to do reverse T3 to roll out it is CQ thyroid or really hypothyroid. If reverse T3 is low, we need to start thyroxine. If reverse T3 is normal or high, you need not, it is a CQ thyroid and you need not start any thyroxine levels. That's what.
Yes, sir.
Is it right?
Yes, sir.
Any questions?
David, but If you think it's HPA axis suppression, then you may have like both adrenal insufficiency and low metabolism hypothyroid picture. Probably that time we may have to start like both thyroxine and steroids, right?
Yes, madam. Yes, yes. That reverse T3 should be checked further.
Okay, fine.
Thank you, Samya. Nice presentation.
Thank you, sir.
I will send this PPT to the group. Okay.
Okay, sir.
Thank you,
you all.
Soumya.
Thank you, ma'am.
Thank you all for active participation. Thank you.
Thank you.
Thank you, David.
Thank you, sir.